Thank you so much for convening all of us around this important topic. Next slide, please. So whenever I talk about oral health and trying to increase awareness about oral health and systemic health, I really always have to start off with this. What are we talking about? Who are we talking about? Who really needs us the most? They have the least and need us the most. And that brings me to the vulnerable and underserved populations, and not only in oral health, but period. So they are, most of us have already been talking about this. Most of you have already been talking about this. Those folks that are low income, the racial ethnic minorities, immigrants, non-English speakers, children and older adults, pregnant women, rural and urban underserved populations in urban areas, and those that are living in food deserts. Of course, people with special health care needs and the disabled and undocumented individuals. Next slide, please. So some of the barriers to oral health equity are very similar to those that we've already heard before. Basically having to do with access to oral health care and the availability of dental providers that take certain kinds of public insurance. Medical referrals, that's another thing. We'll talk about that a little bit later because we don't get enough of those. Social economic status, the fact that dental insurance is separated from medical insurance, and there are 74 million people without any kind of dental insurance. And of course, we will talk about the nutrition elements and the fact that when you have a low education, you don't necessarily not only have a high level of oral health literacy, but in so many of our patients, there's a lack of a perceived need because oral health has been so marginalized and so separated from the rest of the body. Believe me, sometimes people don't even think about the mouth being connected to the rest of the body. It's a whole education process. And sometimes not just for the community at large. Sometimes we need to reinforce those lessons in our non-dental health professional colleagues. Next slide, please. So I'm talking about the vulnerable populations. Again, we also have to talk about the social determinants of health. And I really don't need to go into all of these, and maybe we can make up some time because my other colleagues on this program have already talked a lot about these. So next slide, please. But I will talk about what some of the root causes of inequities in oral health are. So we know that there is that thing about separate insurance. It's bad enough that we have 27 or 28 million people that don't have medical insurance, but it's worse that it's 3 times the amount of 75 million people, 74 to be exact, that don't have dental insurance. So the other thing is with regards to structural racism, yes, there are reasons why a lot of our people don't have insurance at all, period, because they're not, the insurance policies are definitely tied to employment. And in a lot of situations, some of the most vulnerable patients don't have the luxury of being offered health insurance, much less dental insurance at their jobs. The other thing that we will talk about is, and I'll skip over underrepresented minorities for right now because that is a huge factor to this whole thing. But I will talk about knowledge gaps between dental and non-dental health professionals. And that also is a persistent problem and a persistent challenge. And I think it really begins, as we know, everything begins in the health professional training curriculum. So because there are 160 medical schools and only 54 dental schools, you don't always have a situation where you even have dental and medical schools together. And sometimes if you have institutions where the medical and dental schools are existent, They're not on the same campus. So it doesn't provide a lot of opportunity for medical and dental students to even know each other, much less work with each other and be able to do community service projects with each other, which I find is one of the best ways to really, really increase collaboration. The silos are there. They're there in education, but then they're also there postgraduate and out in mainstream, that mainstream America, and also within the health systems. There are too many silos. So when it comes to the affordability and availability, we do realize that if you question people about why they don't get dental care, 50% will report that because it's too expensive, and but another 41% have reported that they can't access a dental provider either because of distance away from the closest dental facility or the fact that there are no dentists available that will treat Medicaid patients. Next slide, please. So when it comes to dental disparities in children, few people really know that tooth decay is 5 times more common in children than asthma. And children from low income areas have the worst dental health at all across all races and ethnicities from age 2 to 5. They 17% more cavities in primary teeth, at triple the rate of cavities in the higher income children. And even in the age group 6 to 19, they're 15% less likely to receive any kind of preventive dental care, especially like sealants. But I will say that when it comes to sealants in dentistry, we are nowhere near where we should be in terms of our children having sealants on their teeth, a very simple preventive measure, the same as fluoride varnish. We're nowhere near where we can be. So when we talk about race-specific data for children 2 to 5 years old with regards to cavities in their primary teeth, Hispanic and Mexican American children have 33% more higher rates of tooth decay, Black children 28%, and white children only 18%. Next slide, please. So when we're talking about toddlers and we're talking about early childhood caries, we're talking about the fact that we really want for pediatricians and pediatric nurses to feel comfortable doing a real intraoral screening as part of a child's wellness exam. So the National Dental Association has come up with training programs. We've trained hundreds of nurses to be able to feel actually comfortable doing this because they may have the courses in didactics in their curriculum, but we actually have to train them on how to do intraoral examinations on each other so that they really feel comfortable doing it. Next slide, please. And I'm so glad that Dr. Puri was talking about prenatal dental care because this is an area that I have been focused on for the last 5 years, going around the country and giving seminars and lectures to what I call interprofessional audiences so that everybody realizes that pregnancy is one of the most important and critical times of life for any woman. But in America, less than 30% of pregnant women have a dental visit during their pregnancy. So a dental visit is not even considered to be routine, a routine part of prenatal care, and it should, because 75% of pregnant women have pregnancy gingivitis. The inflammatory cells are definitely going to cross the placental barrier, just like infections that may be coming from deep decay. And when that happens, the unborn fetus then becomes more highly susceptible to cavities when they're young children. So we teach all of these things to the pregnant women, and the fact that poor oral health has a definite impact on negative birth outcomes. Next slide, please. So when we talk about the oral systemic link and what really happens when these microbes, when we have the bacteria from infection or cytokines from inflammation, what happens when they travel through the transport system of the body and go to these other organs? Well, a lot happens. And in the next few slides, we'll realize exactly what the links are and how much more research there is. But before then, just realize that only 12% of the US population has any kind of oral health literacy. So that's like 85% of the US population really is not aware that oral health is linked to the adverse pregnancy outcomes, cardiovascular disease, respiratory disease, diabetes mellitus, and other health issues. I'm telling you, so many people seem to forget that the mouth is connected to the rest of the body, and it's a reservoir for diseases that can definitely impact and influence systemic health. Next slide, please. So if we talk about the oral systemic link, and if we are about the business of continuing to retrain and to remediate some of the thought processes of our other health professional colleagues, we're constantly reinforcing and constantly reminding. And for me, constantly reading the latest research and the most updated information I have, because every time I pick up a dental journal, it lets me know that there's yet another link that has been discovered through current research. So we already know that poor dental health and diabetes have a bi-directional kind of relationship. But what you may not already know is that a lot of times I have asked physicians for patients' A1C. If a patient comes to me and I'm doing a clinical examination, I see huge tooth decay and I see huge abscess on the gum that's associated with the tooth decay. And I have had discussions with physicians who, number one, are asking me, well, why do you want to know about A1C? You're only a dentist. And then I've had physicians say, well, the readings and the measurements are just fine. I'm saying, I am looking at this infection on this tooth, in this mouth. The patient will definitely need an extraction. We can't extract with so much infection, and I need to know what your readings are showing. The point is, when you have normal readings, whether they're glucose or A1C, they don't always pick up the fact that the patient could have large infection, a lot of infection going on where the teeth need to be extracted. They definitely can't be if the A1C is not right. Next slide, please. So the other thing, they're now getting more research, and we're now reading more about sleep disorders and how it induces systemic inflammation, periodontal disease. We already know the impact that it has on high blood pressure, but what is not known so much is that dentists are usually the first ones to be able to diagnose obstructions of the airway, and also the ones that can help change that. So then the question is, why are the dentists asking for sleep tests, diagnostics? Because there's a reason for that, because we know that we can help it. Let's go to these latest stats with men and periodontal disease and how they have higher chance of developing kidney cancer, pancreatic cancer, and also other types of blood cancers. Next slide. So COVID-19 and oral health disparities, I just have to tell you, I have not seen anything like this. Now, initially, when the dentists heard that so many of the COVID patients had to be intubated, our first inclination was, oh my gosh, We know that in these kind of situations, the frontline personnel are not even thinking about, can't, never do any kind of intraoral screening to even be able to determine whether or not the patient already has advanced periodontal disease. So we have cases where we already have all of this disease, microbiotic and all the flora and everything else that's harbored in the mouth when the intubation is pushing more oxygen and more disease from the oral cavity, okay, into the lower respiratory areas. But at the time when all of this is going on, of course, people are trying to save lives. And regardless of the fact of whether or not the frontline people or the ER people ever do an intraoral examination, you know, nothing hurt me so badly, digressing just a minute and I'll be finished in just a minute. Nothing hurt me so badly as when I read about the story about the 12-year-old Diamante driver who died because of untreated tooth decay that had spread to his brain and caused septicemia. So after 2 operations and 6 weeks in the hospital, the little boy died and his school was 5 minutes from my house. And really, really, that's when my whole life changed and when I started becoming focused on this whole thing about education. So we know that periodontal disease impacts COVID and that people with dental disease are more likely to be hospitalized for COVID-19. But what most people don't know is that the latest research is finding that the virus is harboring in saliva. So when we start talking about mitigating aerosol sprays that may happen in a dental office, people also don't know that there are pre-rinses that are being used in order to oxidize the virus before any dental procedures are being done, which are minimizing this. Next slide. So the last couple of slides are on oral health equity challenges. We talked a lot about the fact that it's a fragmented system, dental care separated from medical care. We talked about the fact that there's a shortage of dentists, but I didn't tell you that in the last 50 years, African American dentists have comprised less than 4%. We're kind of like the dermatologists. We're still at that plateau of 3.8% of the 200,000 practicing dentists in the US are African American. We didn't talk about the fact that some of the barriers to increasing the number of African American dentists are the fact that when the average dental student graduates from dental school, they have $292,000 in debt. When the average Black student graduates from dental school, they are between $350,000 and $450,000 in debt. So, ladies and gentlemen, when you couple that with the fact that a lot of our dental school students are finding their partners and their soulmates in dental school, if you can only imagine a dental couple graduating from dental school with $800,000 or $900,000 in debt, how do you do that? How can you possibly set up your practice in a facility in an underserved area with populations that can't afford to pay the full price and still pay back their dental loans? So we talked about dental insurance coverage. We didn't talk about the fact yet that there's no dental insurance coverage in Medicare. And in 15 states, Medicaid does not offer dental care or even emergency dental care. Next slide. So when we talk about closing the gaps in oral health, we do have to educate our patients on the risk of what happens if they don't have any treatment, for example, like prenatal care, not including dental visits, and wellness visits for children, not even including an oral health screening. We do need to standardize dental care. We do need to work with programs where we can do more preventive treatments in school-based programs, fluoride treatments, and sealants. We need to promote dental care in community settings, mobile dental care, And we do need to expand and diversify the dental care workforce, and that does include mid-level providers and dental therapists. The call to action for oral health would definitely be to try to promote more inclusion of oral health in the medical school curriculum. The last study that I read still showed that almost 70% of medical and nursing students have less than 5 hours of oral health in their curriculum. And that's including the 4-year undergrad medical school program and the 5-year residencies. We do need to try to integrate oral health into universal health care coverage and primary care. There must be a team-based approach to population health, and this is something that we've been able to achieve with our nursing training program that we do annually in New York at the Javits Center during the Greater New York Dental Meeting. And we do need to find a way to change some of these policies so that you do have increased provider dental reimbursements. And even with the dentists who still take private dental insurance, I can tell you when it comes to structural racism that impacts the few African American dentists that we have, there is redlining according to zip code. There are much lower reimbursement rates for African American dentists practicing in African American communities. And yes, we do shoulder an excessive burden of wanting to make sure that we are the ones that are there, the trusted providers and the ones that are listening to our patients and directing them, hopefully, to the right kind of care. But in shouldering that extra burden, there's a lot that we sacrifice in order to be able to do that, which could be changed and should be changed by providing more incentives, tax incentives, or other kinds of incentives for young dental graduates who want to serve in vulnerable communities.